and few are my old students, and few are the consultant. Mrs. Chan is Dr. Chan is the consultant from NHMMI. Few are my old students, and few are about to join. So it's really honor to host Dr. Manish Pandya, a very close friend of mine, a very learned person. Let me introduce you, sir. Dr. Pandya is the HOD of Mahavir Hospital and Manish IVF Center in Vadodara, Sundarnagar. Sir is already running a ultrasound training center. I think sir has witnessed lots of books, chapters. He has the 8 book by JP Publication, 3 chapters in postgraduate reached by BI Publication, 1 chapter on DUB. He is a training in ultrasound and pelvic and infertility training centers at Manish IVF. And for me, he's a very close friend. I think we met in 2010, Sunny.
Yes,
In
probably,
a
madam.
yeah, probably 2010 when he was the faculty in I2. And since then, I think we are associated. He came to Bilai when I was secretary. Again, he came to Bilai when I was the president. So basically, today class is from the basic things like infertility scan. What we are doing on second day, gradually how we are monitoring the follicles, the endometrium, and I will request her to keep in a very low pace to understand the basic things. And I request all of you, but I feel learning is a constant process, and it is never, you can say it's a daily process to be done. And when we communicate with each other, I think then only we learn. So I will request all of you to be very attentive because it's a closed group, and I have requested Pandya sir to take the class for 45 minutes, and another 15 minutes will be to clear our queries. The chat box below, you can put your question, put your paper and pen, so that even minor queries can be cleared up. And believe me, no question is wrong and no question is right. So I think everybody is joined. Only Meenakshi, one of my fellow. जितेन एक बार देखेंगे मीनाक्षी मैडम का क्या हुआ, आ रही हो जा रही है, उनके लिए सबसे बढ़िया मीनाक्षी is there. So now over to Pandya sir for the basic infertility scan.
Thank you, Sangeeta ji. Thank you for kind words. And it's honor to be with Bhilai because Bhilai is very much near to Champaran. So it is very much near to my heart. So every time I visit Bhilai, you made me to visit Champaran, and that is the birthplace of Mahaprabhuji. So today we are talking something regarding the pelvic ultrasound. It is a basic ultrasound, how you should look into the pelvis. These are some of my credentials, and I will request all students to scan this. They will show my 110 research work over there. And we have got 2 research fellow in diploma in DNB since this year and up to 2027. We have got fellowship in reproductive medicine and laparoscopy for ICOG class also. So welcome to webinar organized by Surgeon Hospital and IVF Center. How beautifully everything is arranged by Almighty, that as soon as child enters this world, mother is ready to take care of it. Said by Rajnish ji, with the blessings of mother of mine and so many mother to whom we had made. 3 book written by us is recommended in Royal College as the reading material. Likewise, the technique of IVF made easy, and the technique of fetal echocardiography has gone for 2nd edition. I am editor-in-chief of 2 journals, so those who want to publish their work, they can contact, and both are Scopus Journal. We had worked as a KOL, and recently I got opportunity to interview Professor Herman Tourne in Copenhagen ASHRE 2023, and you can see all this interview plus so many educational video in Manish 4269 channel. Today we are flooded with technological innovation. There are 2 type of person, those who believe like me and those who don't want to believe, they are skeptics. There is a tug of war between these 2. Ultimately what wins? That is the scientific evidence. When we talk about the scientific evidence, we always see the risk versus benefit ratio and cost versus benefit ratio. Believers are there, those who can walk, and they can work very well. So we have to work like believers and make universal adaptation in the practice of ultrasound. Today my presentation is divided in infertility and tumors. If you would like to continue, we will talk something regarding tumors in the last slides. First we will talk regarding the infertility. Infertility is very common, and if you talk about infertility, we must think something regarding the uterine anomaly. We must know how to do ovarian assessment. What will be our endometrium, and some word regarding the sonosalpingography. First, we will talk something regarding uterine anomaly. Usually nowadays, if you are able to do 3D ultrasound, it's just like virtual hysteroscopy. And recently we had published paper, it will replace just like your 3D ultrasound, which looks very well, just like hysteroscopy. You can see ostia, you can see very well endometrium, and sensitivity of volume ultrasound is 98% and specificity is 100%. Which are the anomaly we have to look for? Uterus may be unicornuate, bicornuate, septate, didelphic, and sometimes DS related. What acquired? Because since birth we don't have fibroid, adenomyosis, polyp, or Asherman is totally caused by gynecologists like us. First, see this picture. Identify the uterus anomaly. This is one uterine horn. If you see like this, it is a unicornuate uterus. Uterus deviated to one side. Usually it is banana-shaped uterine cavity on 3D ultrasound. Second anomaly. Identify this. This is uterine didelphys, or you can call it a bicornuate uterus. Two uterus and cervix. It has got best prognosis if they are both separate and both cervixes are there. Another uterine anomaly, bicornuate uterus. Endometrial cavity usually convex medially. If you measure the angle, it will be more than 90 degree. Less than 5 mm distance between the fundal dimple and endometrium, myometrial layer deepening. Look at this. This is angle more than 90 degree. If you see the dimple, it is myometrial dimpling is there, and this is 2R this 2R endometrium, and this is myometrium. So you can see this is a bicornuate uterus. You can see dimple more than less than 5 mm distance between the fundal dimple and endometrium. This is fundal dimple and this is the endometrium. Another uterine anomaly, septate uterus. How to diagnose between the septate and bicornuate uterus? Endometrial cavity straight medially. Previously it was convex. Angle is less than 90 degree. More than 5 mm distance between the fundal dimple and endometrium. This is fundal dimple and this is the endometrium. More than 10 mm distance between the deepest point and top of the endometrium, and minimal fundal indentation. You can see very well. This is angle less than 90 degree. The cavity. This is another uterine anomaly, arcuate uterus. Endometrial cavity concave at the fundus level. Angle is more than 90 degree. Less than 10 mm distance between the deepest fundal point and top of the endometrium, and external fundal counter may be flat or may be convex. That depends. So you can see angle is more than 90 degree. The deepest point, it is more than 10 mm from the top of the endometrium. So just remember this. If you are watching bicornuate, it is concave. Septate, it is flat, and arcuate may be septate or flat. Most important differentiating factor is fundal endometrial tip distance. Less than 5 mm bicornuate, more than 5 mm may be arcuate, may be septate. But see the angle. Angle is more than 90 degree and more than 90 degree in arcuate uterus, while less than 90 degree in septate uterus. Endometrial tip to pit distance more than 10 mm, less than 10 mm. Endometrial shape may be convex, flat, and myometrial deepening usually present in bicornuate uterus, while it is absent in septate uterus. T-shaped uterus, that is DS toxicity. You can see there is no waist. It is just like parallel or T-shaped uterus. You can see this is a T-shaped uterus. So these all are the congenital uterine anomaly. What are the acquired? In acquired, we can see fibroids. Fibroids are the benign growth of uterine wall that occur usually in 25 to 50% of women. Fibroid develops within the wall or surface of the uterus. Everybody knows there are subserous fibroid, there are submucous fibroid, that is intramural fibroid. Most important thing is surgical removal. If you are able to do laparoscopically, then it is well and good, and if it distorts the endometrial cavity, then you must remove even 2 mm or 3 mm fibroid which is disturbing the cavity, and more than 5 centimeter fibroid which is lying subserosal, which is lying outside the uterus. It doesn't cause any problem. But fibroid is inside the uterus in the endometrial cavity. You must remove that fibroid. See the ultrasound of fibroid. This is a big fibroid. This is cervix, and now you can see there's a big fibroid over here. One fibroid is here, one fibroid is here. So in this type of uterus, we have to remove the fibroid and give benefit of pregnancy to this type of patient. But so many times there is a small endometrial polyp that we can remove very well with hysteroscope. We can remove this with loop, and you can remove this fibroid or polyp from the uterine cavity, and you can give pregnancy to those ladies. And this fibroid will disturb the pregnancy in utero. So for get very good endometrium, we must remove this fibroid. So this is fibroid, this we have to remove. This is fibroid, this we have to remove. So there are 3 different varieties of fibroid. Type 0 is pedunculated and inside the uterine cavity. Type 1 less than 50% in the cavity, and type 2 type 1 is more than 50% and type 2 is less than 50% in the cavity. You can see there is a fibroid inside the uterine cavity. Here there is a fibroid, and same fibroid we are removing through hysteroscope. The same fibroid we are removing through hysteroscope with loop electrode, and this is done with monopolar current, and we are using glycic. Nowadays we have got facility of using normal saline, and there is bipolar resectoscope is also available in market. So you can remove this fibroid, and you can see this is ultrasound. So when you are performing any surgery for submucous fibroid, always map the fibroid. You see that this fibroid is lying in the posterior cavity. So don't look at another cavity. First, always do very good mapping and then start your surgery. So it make your job very easy. Always count the number. See the feeding vessel from where the vessel is feeding to the fibroid. So you can coagulate it, and you can very well chop up this all fibroid and remove via the ovum forceps, and you are removing this. Likewise, surgical removal of fibroid is ultimate. Laparoscopic myomectomy, hysteroscopic myomectomies are very good for fibroid surgery. You can see that there are fibroids which are making pregnancy in utero also. There is a pregnancy with fibroid. You can see there is a 1 or 2 fibroids are there, but they are subserosal fibroid. You can see one fibroid is here, one fibroid is here, and baby is lying in utero. So there are fibroid of 3 to 4 centimeter. But these all are not protruding into the cavity. So once the fibroid which are not disturbing the cavity, you can very well continue the pregnancy. You can advise patient that if fibroid is not disturbing your uterine endometrium, you can continue the pregnancy. And if you are surgically well versed, you can remove this fibroid during cesarean section. And we are the center, we are removing all fibroids, or we are doing cesarean myomectomy. So patient is saved from another surgery post cesarean section, and it is very easy to remove all these fibroids. Sometimes bleeding are there, but it will be tackled with both internal iliac artery ligation if it is there. So always do cesarean myomectomy in this type of patients and allow the patient to become pregnant when fibroid is not disturbing the cavity. You can see we are doing 3D of this fibroid, and you can see that fibroid is not disturbing the cavity even though fibroid size is 3 to 4 centimeter. They are lying near the isthmus, so it may disturb or it may harm during your cesarean section scar. But when pregnancy advances, fibroid is also advancing, increasing in the size. And beware, sometimes you have got red degeneration of fibroid. Red degeneration of fibroid is also there. So don't worry if the fibroids are there. Then this is another case of interesting margin of lesion. You can have a Swiss cheese endometrium, myometrial cyst near the junctional zone, and radiating and perpendicular vascular pattern. Can you imagine what is this condition? This condition is known as adenomyosis. Adenomyosis is nothing but endometriosis internal. You can see cystic structure like this over there. There are small cysts. This is are the endometrial cyst, and this patient's uterus is increasing the size. In the both myometrial endometrial junction is increased. If you put vascularity will be there, and there are so many endometrial cysts. Nowadays we are doing laparoscopic adenomyomectomy. At least 50% of the adenoma we can remove and we can give this uterus to become pregnant. Believe me, you don't have to remove 100% top adenoma. You can remove 50%, then they take very good stitching from side to side and cover the endometrium very well, cover the serosa very well. Then after 3 to 4 months, you can allow this patient to become pregnant. You can see if you are doing putting color, there is lots of color is there. Color is very good friend of yours. With color, you can see vascularity and you can see that how much endometrium you have to resect laparoscopically. Then polyps, uterine abnormalities, small polyps. There may be single, there may be multiple. You can have a feeding vessels, but polyp sensitivity of ultrasound is 92.9% with positive predictive value. You can see synechy also with better seen with sonosalpingography and have more than 100% sensitivity is there for synechy, and with 3D ultrasound you can see synechy very well. Second is ovary assessment. How ovary is responsive to you. There may be different type of ovaries you can see on ultrasound. Ovary may be normal, polycystic, poorly responding, and sometimes low reserve ovary or very low antral follicle count will be there. Always see ovary on day 2 to day 3 if you are practicing infertility. On day 2, see the ovarian diameter and volume, counter antral follicle, do very good ovarian stroma assessment, and if you have got facility of RI and PSV of the stromal vessel, do it, put it on a graph, take good 3D volume. With 3D, so many antral follicle which you are not visualizing in 2D that will be available in 3D in a volumetric count, and see global VI, FI and VFI. This is 2D assessment of ovary. You can see multiple antral follicles are there. You can always see ovary in 3-dimensional length, breadth and breadth, and always take the volume. That will judge that whether this is ovary is polycystic or not. You can also put color, and color PSV should be less than 10 centimeter per second. You can see vascularity of follicle over there, and this vascularity will help you to decide for ovulation trigger, for IUI. So always see perifollicular flow. Whenever you see follicle is mature, always see endometrium. Endometrium is very good, more than 8 mm endometrium is there. Here you can see markings are of 1 centimeter, so you can see it is less than 1 centimeter, it is 0.8. You can see vascularity is going very well in zone 3. We will see this type of vascularity in USSR, that is Applebaum score, that is uterine scoring for assessment of ovarian volume or infertility. Here you can see very good follicular flow. Here you can see perifollicular flow. This perifollicular flow, it is more than 70%. This follicle is mature. You can give trigger and IUI result will be very good. So always see perifollicular flow when you are going for trigger. So when this technology is available, it is for all of us. You must avail that technology. You must know how to apply this technology, what are the different indications, and always make your skill of useness of this instrument. You have to develop your skill to interpret it, because if suppose I have got helicopter and I don't know how to drive helicopter, then it doesn't got meaning. So whenever you purchase any machine, see the in and out, front and behind of the machine, see what are the different buttons are there, what buttons are used for this. Always take presentation of knobology, how many knobs are there in your button. So often it is translated for the available information to improve patient care, which is lacking. In 1780s, when we started ultrasound, it was very basic ultrasound. Probe is weighing 7 kg. It is available only for the referral center. There are fears of harmful effect of ultrasound. We are doing only in the indicated scan. Recently, I got presentation in SOGO of inverting diagram pyramid of antenatal ultrasound. So now we have got the 12-week opportunity. Do all three things between the 12 to 14 weeks and do benefit to your baby. So baby should not deliver congenitally or structurally abnormal. In 80s, we have got concept of 18 to 20 week, and currently we are doing ultrasound in 11 to 40 week. Particularly in ART, we don't want give any anomalous baby to our fetus. So this is the standard of care nowadays. So does ultrasound technology fit for all? Yes, because it is easily available. Now it is just like a stethoscope for obstetrician and gynecologist. Gynecologists cannot afford without ultrasound. Everything they are doing with ultrasound. Ultrasound is just like stethoscope for obstetrician and gynecologist. It is a cost effective, and now it is available in very remote part of the country also. Then 3D ultrasound came in market. With 3D, you can have a very good investigation of the uterus, ovary, and fallopian tube. If you are able to do hycosi or you are able to do HSG, you can very well narrate the uterine pathologies such as myoma, carcinoma, and you can also predict the outcome before IVF pregnancy. 3D ultrasound shows more accurate calculation of uterine volume, and it also helps to more precise estimation of endometrial morphology and volume, and we can call it as a sonoendocrinology. With sonography, you can predict what will be there in the endometrium. With sonography, you can predict that on which day you have to transfer your embryo. So ultrasound performance, it is non-invasive, painless procedure. It is essential for IVF. No IVF specialist do IVF practice without ultrasound. From the monitoring, for pickup, for transfer, everywhere you will require ultrasound. Ultrasound frequency raised from 1 to 8, and now we have got 14 or 16 megahertz probe also for different penetration and for different uses. 2D ultrasound, traditionally black and white ultrasound, it is two-dimensional, very useful. To learn 3D ultrasound, you must know how to do very good 2D ultrasound. 3D is luxury and 4D is just like Mercedes. You can have exact technology, you can make baby move, you can make your patient happy when baby is clapping, kissing, crying, or doing namaste to mother and father. For day 2 ultrasound, always look for perifollicular flow, just like we had seen on, and you have to see what will be there. Always see 3D ultrasound. This is a niche mode of ultrasound. You can see every layer. The cavity, which is just like tubular, may become circular. You can see whether there is fluid is there or not. Same thing you can do abdominally also. Same thing you can do vaginally also. Whichever way you are comfortable, do very good ultrasound. And here you can see both tubes are there in this 3D ultrasound. You can see both ostia is also there. So this is a virtual hysteroscopy. With hysteroscopy, you can see everything, just like you can do this with very good 3D ultrasound. So always take very good volume. Now we are taking very good volume. This is area of interest. Now you put it in a plot X, Y, Z. Move accordingly according to your needs. The C image will be transferred over there. Now you can see very good triangular endometrium. You can see both ostia is there, no polyp, nothing. With 3D ultrasound, you can have a very good baby in utero. This is 3D ultrasound of abdomen. You can show baby very well to the fetus, to the mother, and they are very happy. So 3D is luxury. 4D is just like Mercedes. You can make baby clapping. But for that, believe me, 2D good ultrasound learning is utmost important. A 3D ultrasound can only acquire if you are very good in 3D ultrasound can only acquire if you are very good in 2D ultrasound. In IVF, we are more concentrating on the antral follicle count. What is this? Antral follicle count is one of the best marker for ovarian reserve. If we combine AFC with AMH and age of a mother, is considered best marker for ovarian reserve. AFC is used to predict the response of gonadotropin when we are assisting in ART, and AFC also informs clinician about the quantitative ovarian reserve. How you can count AFC? You have to do baseline scan. This is a baseline scan. You can see endometrium is always follow the rule of 5. There should be less than 5 mm endometrium. Estrogen should be less than 5. Progesterone should be in the range of 5 to 50. No vascularity, no cyst. This is the endometrium. You can see endometrium, it is 3 mm only. On both the ovaries, you see very good endometrial count. You can take 3D volume of that endometrium if you are not sure. You see, this is a 3D volume of endometrium. You can see very good triangular endometrium over there. Just move your probe X, Y, Z. The C image will be moved on your 3D screen. Yes. Here you can see very good endometrium over there. and then go for this ovary. Both ovary you can see. Here you can see both ovary. 1, 2, 3, 4, 5 enter follicle count. In another ovary you can see both. You can count it. You can measure it before starting for gonadotropin. You can take 3D of this both ovary. Here it is a volumetric control. You can take this ovarian volume, make a good 3D sweep. The follicle which is lying behind, they are visible over here. And if you make automated count, machine will count for you and it will give you what are the different follicles are there. This is 1, 2, 3. Here you can see very good volume of that follicle. So it is very easy with 3D ultrasound. You can see 1, 2, 3, 4, 5. There are 3, 4, 5 follicle is there on one side. Then take volume of the opposite ovary. These are the day 2 scan. You can take very good volume. This is a 3D volume. The follicle which you are looking 3, 4, they are more in the number because we are taking very good coronal section. When we are taking this 3D ultrasound, you can see this all follicle and there will be color coding. If you put automated follicular count, they are color coding. 1, 2, 3, 4, 5, 3 and 3, 6 follicle are there on the another ovary. So this is a very good baseline scan. Then you start your ultrasound. This is another case of day 2 baseline scan. You have to do very good scanning. You can see endometrium is very good. You can take 3D volume of that uterus. It is a sweep. Here you can see very triangular endometrium, no polyp, nothing. Here you can see very good triangular endometrium is there. So this is a very good endometrium of day 2. So this is a very good endometrium, baseline endometrium. You can see both tubal ostia is also, this endometrium is also going in the tubal ostia. So everything is fine, nothing abnormality. Then you can take this over. 1, 2, 3, 4 follicles are there. 1, 2, 3, 4, 5 follicle you can see. Now you put on automated count. This is a 3D volume. Take 3D volume, arrange in XYZ manner, cut this part of ovary. Here you can cut this part. So you can see all follicle and they will be automatically counted by machine with color code. You can see these are the artifact, but one can see 1, 2, 3, 4, 5, 6 follicle are there. Likewise second ovary. Take the volume of ovary with 3D probe. Put it on a XYZ manner. This is X, this is Y, this is Z and this is C image. So you can see A, B and C. This C image will be depicted as a 3D image. Now put color coding. You can see 1, 2, 3, 1, 2, 3, 4, 5, 6, 7 follicles are there on day 2 baseline scan. Then you start your gonadotropin. Then you start your gonadotropin. You can get very good 3D volume of also for this follicle. This is a follicular 3D. You can see how beautifully this follicle are seen on 3D ultrasound. You can see these are very good follicles. You can see, you can count on both this follicle very well. So it is easy to do when you have got 3D follicular velocimetry. You can do it very well. You can measure this follicle. Here you can also see cumulus also. These are the 2 follicles that if you measure it is 15 and this is 22. But on ovarian assessment volume you are taking and then you can assess that this follicle is very good for IUI. This is not for IVF pregnancy. This is sono AVC, which still I am talking about. What you have to do on ultrasound in sono AVC. This is very good endometrium. You can imagine endometrium is of 10 mm. So once you have started, this is very good vascularity. Vascularity is going in zone 3 also. This is zone 1, this is zone 2, then this is zone 3 and this is right going up to the endometrium. So this follicular get vascularity is very good. We have stimulated ovary. This is a stimulated ovary, good 3D of volume of ovary, 1, 2, 3. On another scan, another 2 follicles are seen. On another scan, there is third follicle are seen. So we are just taking different TUIs or different section of ovary. So we know that 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 follicle will grow. So take this sono AVC of this patient, first count by itself and then do good, very good 3D. Put your 3D box over the ovary, capture the skin. All 3D will be taken by the machine. There are different sections they are taking from coronal, sagittal and transverse, and they are putting on this volume mode. If you cut this from here, this will be your cutting line. You can see this cursor is going inside, this X is going inside. So this is a curvilinear mode. And with this mode, you can see very well follicular count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We had already counted 10 follicle in 2D ultrasound. In 3D, we are confirming it. Likewise on the second ovary. 2 follicles are there. 2 follicles are there. Okay, so you can measure this follicular growth like that on sono AVC. Then serial measurement of follicle. On next visit, patient is coming. Also monitor the follicle. See the uterine cavity. Uterine cavity is very good. See for automated count. This is, you can measure the uterine cavity very well. Same way you have to do for serial monitoring of the measurement of the follicle. This will be your day 5 USG. On day 5, you will see endometrium is very less. So you can stimulate, or if you want to do for IVF, you can also use gonadotropin. Again day 5 scan. This is sono AVC for follicular count. So what you have to do on day of HCG? This follicle are growing. You can see the number of follicle will be very good. There are so many follicle which has reached more than 14 or 16 mm. You can see cumulus pupurocus is also there. These all are the cumulus follicle. And if you put it on 3D graph, they will give you very good 3D monitoring of this graph. This is second ovary. You can put very good 3D volume over there. So machine will count automatically how many follicles are there. These all are the mature follicles. This ovary has got cumulus within. So take very good 3D. There are so many follicle are there on the day of HCG. So you can have a prediction of number of follicle or number of ova once you get post pickup. So you can tell your embryologist that I have counted 1, 2, 3, 4, 5, 6, 7, 9 and 10 follicle on one side of ovary. So it is my tendency that I will get more than 14 follicle, 14 ovum from this ovary, on the day of induction. Then do pickup. Always do pickup on 2D ultrasound. Whatsoever 3D ultrasound will be there, never use it. First fix your ovary. This is the line. This is the path from Surendnagar to Bhilai. You have to go on this part. Never lose your needle. Always puncture the needle within your reach. You can see echo tip of this needle. Your assistant always say coming, 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 and follicular fluid is coming. You can see collapse of this follicle. Once it is right there in the proper plane. Yes. With this thus it is going. Now you can see follicle will be aspirated. Then one by one you have to take follicle. From one follicle, never try to take follicle which is last one. Second follicle naturally comes in the position. Just pick your needle. You can feel the resistance. Once completing of one follicle, there and then enter into the second follicle. Never puncture more than 2 inside the vagina. It will cause bleeding. Now I am going in the second follicle. Follicle is aspirated and you can see collapse of this follicle. Naturally, this third follicle will be in the line. So always take follicle one by one. Little bit withdraw. Make follicle align. Make follicle align. Give 90-degree thrust. Don't go tangentially because you are watching only in 2D. Sometimes with practice you can see this follicle is also collapsing. So you are going inside the follicle. Always count that follicle that you have taken this follicle. Otherwise sometimes there are so many refills. So many follicle get refill of the blood. Take one by one follicle from one ovary. Then you have to take one by one follicle from the second ovary. After finishing it, this is the last follicle and here you can see the pulsating vessels. So always beware that ovum pickup is easy looking on screen. It is sometimes difficult. Never try to puncture this vessel, otherwise you will be in the soup, because ovary is usually lying between the two vessels. So always follow this boundary. Never go from this boundary. This is Lakshman Rekha for you. Sita has gone out of Lakshman Rekha, then Ravan has caught him. So better not to go out of the uterine ovarian boundary. Always take whatsoever follicle visible to you and don't try to go beyond the boundary of this. Few words regarding the sonohysterography. It is a recent investigation in the uterine cavity. You can inject saline into the uterine cavity through 5 French Polish catheter or feeding tube. You can see end-echoic interface provided by saline that allows what will be there in the intracavity, what is there in endometrium, and sometimes you can see submucosal fibroid. You can perform on first day of menses. If irregular cycle, perform after the negative pregnancy test. Suspected endometrial polyp, best performed in proliferative phase. If you are suspecting leiomyoma or submucous fibroid, better outcome in secretory phase, as thickened endometrium lining separates that endometrium. You can see there is a very good polyp. Small polyps are there. This is also polyp. This is also polyp seen in the uterine cavity. Big myomas is there. So you can put your Foley's catheter like this, put a little bit of saline and do ultrasound, and you can see what is normal report, how you can write the report of HSG or sonohysterography. The endometrium remains symmetric with single layer thickness, being half the expected double layer thickening for the respective phase of menstrual cycle. If you are doing in proliferative phase or secretory phase, there is no mass or lesion seen in the endometrial cavity. If you see any polyp, you have to mention polyp with diagram also. Embryo transfer technique. The technique of embryo transfer marries with the effort of reproductive biologists and clinicians. Nobody can say I am perfect. We can make very good endometrium, but embryos are not good. They are not ready to go for implantation. Without healthy embryo, no will be there. So we have to got very good soil, very good crop, and very good fertilization after luteal phase support. So it is a combined work of embryologists to maintain the viability of embryo, and we have to do atraumatic transfer as much as follows. Always measure the cervical length from the fundus to the uterus. Then always see your tip should not go beyond the internal os. Always put your embryo at the level of maximum implantation potential point. We are always doing ultrasound guided transfer. You can see uterus very well into this cavity. Here you can see uterus very well. This is a very good endometrium. Now catheter tip is going inside. You can see catheter tip is going. This is catheter which is reaching the cavity. This is the catheter which is there at the level of internal os. This is outer sheath, and now inner sheath is there. Now embryo is ready for fire. So you can put embryo here in the maximum implantation potential point. When the embryo get fire, because we are taking double sandwich technique. So first will be there is media, then there air, then embryos, and then again there will be air. So 2 packet of air is there inside our catheter with very low volume of media and very low volume of media with embryo. So embryo is stuck between the 2 air bubble and it is going inside the uterine cavity. You can see there is very good flush of catheter over there, and you can see embryo is placed in a maximum implantation potential point. Here you can see the flush of embryo. Now you can see embryo just got blasted here. So these are the embryo which is putting under the ultrasound guidance. So perfect embryo placement, 2D has been widely used in transfer. We have to calculate distance from the fundus. 3D has enabled accurate non-invasive diagnosis of uterine anomaly and easy estimation of catheteric position in the uterine cavity.
Concept and technique is to imitate nature, using 3D and 4D.
This is a very good depictive of how you have to put your embryo inside the uterine cavity. Suppose this is uterine cavity. Always see that uterine cavity is in a triangular shape with both ostia. which is opening, because we are putting ourselves inside the endometrium by just dropping theory. We are dropping our cells at the level of blastocyst from here into the uterine cavity, either from right or left. And when this both line meets, this is the maximum implantation potential point for any embryo. Because by dropping theory, we are putting ourselves into the endometrium. We are eroding our mother's endometrium. We are putting ourselves intrinsically. So if you do 3D ultrasound, you can measure this is a normal sized uterus. Here you can see that this is a different variety of arcuate uterus. So every uterus has got different MIP point because both these tubes are coming at different level. And this is how you are putting your catheter. This is a very good depiction of 3D ultrasound. This is your catheter which is going inside the uterine cavity. And nowadays everybody is doing SCT or single embryo transfer. So single blastocyst will be transferred at the level of maximum implantation potential point under ultrasound guidance. Here embryo is going outside, and you can see the embryo is placed here, and this is a distance from the fundus, this is a distance from the internal os, and this embryo safely placed in normal uterus, in arcuate uterus. You see every uterus has got different MIP point. Here we had put in a this type of uterus. So every uterus has got its own MIP point. So IVF nowadays we have to go for single embryo transfer or SCT. We have to do transfer at the level of dropping down theory or maximum implantation potential is there to get the very good result in all IVF patients. This is how you have to load your embryo, and this embryo is going at this particular juncture. So many times you can get ovarian hyperstimulation syndrome. This is a twin pregnancy with OHSS. So always ready to bear this. It is a nightmare, but mild OHSS will be taken care very well by any efficient IVF specialist. So nowadays we are not giving very much stimulation. We are not making more than 8 to 10 ovums in our IVF practice. And now since 2009 we had not got any OHSS in our patients, and this is 2015 case with mild OHSS, and patient is ready and patient had delivered twin pregnancy with very good taken care. So this is baby in 4D ultrasound. I told that 4D is luxury. You can watch baby like this. Baby is driving a car, and baby is shifting the gear. Baby is also saying salam namaste to you. So this is luxury you can got. And madam, if you want to continue in ovarian assessment or OTA, we will continue this, or we will stop and we will go for question and answer. Sangeeta madam. Hello. Hello. Hello, anybody is there? So I conclude that 3D 4D ultrasound become the indispensable tool. You can compare the patient from initial diagnosis to final embryo transfer. Patient take great comfort in having the ability to visualize the final step through difficult process. And this is the Sono AVC, Sono follicular AVC count. More useful in cases of PCOS to become polygonal, and I've shown how you can take different variety of Sono AVC. You can also take stromal volume. This is a threshold volume. It helps to separate calculation for follicular and stromal volume. This is vascularity index or VI, abundance flow in calculated volume, flow index, that is average intensity of the flow, vascularity flow index, that is VFI, for the perfusion of the volume. Already told, normal ovary diameter is 2 to 3.5, volume 3 to 6 cc, stromal RI is 0.6 to 0.7, stromal peak systolic velocity is 5 to 10 centimeter per second, and enteral follicle count may vary for 5 to 10 per ovary. Polycystics, Rotterdam criteria, more than 10 cc volume and more than 12 enteral follicle. So polycystic ovaries, usually longest diameter is more than 3.5, ovarian volume more than 6.6, more than 12 follicle, hyperechoic, predominantly stroma, stromal RI should be is there always 0.5 to 0.58, peak systolic velocity more than 10, stromal area or volume you can take more than 0.34, and stromal volume of ovarian is more than 75%. This is a typical PCOD ovary, and you can say that this patient has got hirsutism also. So always do very good assessment of polycystic ovarian. This is, you can see the big ovary, more than 6 centimeter square volume is there. You can see multiple follicle in one ovary. In second ovary also you can get multiple follicle like this. This is a typical polycystic ovary. So if you know this, you can ready for OHSS. So always do very low count or low dose gonadotropin stimulation. Sometimes poorly responding ovaries of any size, intraovarian volume of RI more than 0.68, peak systolic velocity less than 5 centimeter per second, with low vascularity, and for this we have to give very high stimulation. So this is low ovarian reserve, you don't see antral follicle or less than 3 follicle. Very high gonadotropin dose you have to give. You can also measure follicular VI. In this type of follicle, you can see cumulus oophoruchus when follicle is mature. So endometrial receptivity and volume is there. You can go for sonosalpingography. You have to do endometrial assessment. You can go for 2D like thickening, grading, vascularity, and uterine artery Doppler, and you can see contraction. In 3D, you can go for volume with vascular indices like VI, FI, and VFI. So this is your baseline scan for endometrial assessment. 2D, functional uterocervical length, length of endometrium and cervical cavity from fundus to external os, and uterine artery RI of 0.6 to 0.8, and PI should be 2.2 to 3.16. Any PI more than 3.5 endometrium is not receptive. You can say this endometrium is not going for fertilization. Endometrial grading, grade A endometrium, it is multi-layered with intervening area of more echogenic than the myoendometrium. You can see this is endometrium, this is myometrium. You can see there is different in echogenicity. Same like grade B endometrium, multi-layer with very good endometrial thickness, and you can see the difference, hypoechic difference from the myometrium. This is grade C, homogeneous. You can say it as a ground glass or pregnancy conducive endometrium. When this type of endometrium is there, the pregnancy chances will be very good. You can also put vascularity, RI of 0.4 to 0.59, PI 1.1 to 2.3, vascularity less than 5 to centimeter area, particularly grade 3 to zone of endometrium. This is Applebaum classification of vascularity. You can call it as a USSR, uterine scoring system for reproduction. So zone 1 vascularity, you can see vascularity is not reaching up to the zone 3. Here you can see vascularity reaching up to the endometrial edge, and this is zone 3 vascularity, blood vessel reaching internal endometrial hypoechoic zone, and this is Applebaum classification of vascularity. Again you can see uterine volume, uterine volume should be more than 2 ml, best if it is more than 7 mm. This is a very good vocal with volume control. You can see vocal very well. You can see vascularity, FI should be more than 20, VFI is best if we get more than 5 with global vascularity parameters. So what we can call good or mature endometrium? Minimum thickness preferably 6, 8, it is good. Grade A of endometrium, vascularity reaching zone 3 to 4. Endometrial RI should be 0.6 to 0.48. Endometrial volume 3 to 7. Endometrial FI more than 20. VFI you get more than 5, then it is really good. And uterine artery PI should be less than 3.2. This we call it the mature endometrium. Sonosalpingography, also known as Sion procedure, because it is designed in Sion Hospital by Professor P.K. Shah. It is very cheap, no anesthesia, no radiation. You can see uterine cavity very well. You can see fallopian tube by putting fluid into the uterine cavity. You can see peritubal adhesion. It is more than 90% diagnostic, like hysteroscopy and laparoscopy should be avoided. Cytoblock is very difficult to diagnose, but you can diagnose septate uterus. You can diagnose patent tube over there. You can see both the tubes are very well seen. So you can see patency, you can see normal uterine cavity with polyp. If you have got facility of icosi, this is very good contrast medium you can add in the uterine cavity. You can see whole tube. Here you can know the exact block of the tubal block, and you can go for tubal surgery or can go for IVF. Thank you very much for patient listening. And if you want to learn more regarding the advanced value ultrasound, we can continue or we can stop and we can go for question and answer.
वॉल्यूम इंक्रीज करो सर.
Thank you, madam.
मेरी आवाज आ रही है?
Yes, madam, आ रही है.
Okay. Thank you, sir, for such a brief and elaborate presentation. Definitely, I agree with you that ultrasound is the cheapest tool with the maximum intervention, you can say.
Yeah.
Like if you have seen good number of AFC, what is the role of doing AMH and all. So, the proper use of the machine is very important so that we can interpret it and make it a cost-effective tool.
Yes, madam.
Actually, I have also queries. But before that, I will request all of my Meenakshi and anyone, if I first clear your queries, then I have lots of queries, sir.
Okay.
Meenakshi, do you have any questions? Yeah, so Lakshmi, please. Sir, अपना screen बंद कर सकते हैं. Yeah, Meenakshi.
Can we differentiate between non-ovulatory follicles and ovulatory follicles by scan? By any way? Whether it is going like it is going to ovulate or it is going to become a like sometimes the follicles is growing up, na ma'am, and it not rupture. So is there any method like?
Yes, madam. That's why I told the better when you are suspecting any follicle, just put your color flow, or you can say the perifollicular flow. You just see the endometrium, put color over the follicle. If follicle is covering more than 75%, if color is covering more than 75% of the follicle, I can have a whiteboard facility over there, no? Yes.
No, they are aware, sir. Perivascular flow, you have to say.
So if it is less than 25%, even though follicle is showing 18 millimeter, it is not going for rupture. Clear?
Yes, sir.
E2 you can also see.
You can also see E2, you can also see vascularity in the endometrium, you can also see cumulus upfuricus, you can also see uterine artery PI, you can also see RI and PI of the ovarian artery. There are so many things by which you can predict that this is follicle, is empty follicle, follicle is not going for rupture, or this follicle is good for IUI and IVF. With ultrasound you can do all these things.
You can see for the serum LH and all. So there are lots of tools you can manage and you can see are you going to give the results or not. Am I right, sir?
Yes, yes, sir.
Thank you, sir.
Yeah. So, Meenakshi, you have any queries? Dr. Meenakshi is the fellow of this. Meenakshi, any queries? Otherwise, sir is going to ask the question.
No,
It's
ma'am.
okay, everything is fine? Okay, Nupur? Dr. Nupur, you have any queries? Sir, we have Dr. Ranjana Chand from NHMMI Hospital. See the sonologist over there. Ma'am, need your comments, Dr. Ranjana. I think there's some network issue. Nupur, you were asking something?
No, ma'am. No queries, ma'am.
Okay, yes, okay. So now there are lots of questions of mine.
Yes, yes, madam. Throw it.
So nowadays, like for the septa, are you going to use loop or you are using the scissors?
Madam, that
Or how
depends.
are you going to decide ki either you are going to use the loop or you are going to use the scissors?
First, I will do very good 3D ultrasound and see what is the thickness of that endometrium, thickness of that septum. What is the vascularity of that septum? I keep all three tools ready before going for histoscopic septectomy. Scissor, bipolar, and nowadays resectoscope is also there. Loop is the top. You can use Kelly's knife, you can cut with loop, and you can cut with scissor also. So depends upon the thickness and vascularity and how deep you have to go. Till today, best tool is scissor because it is always a avascular septum. So if you cut it, cavity will get open. But if you see vascularity, you have to use Kelly's knife. Simple.
So we just wish we should use the scissors, but sometimes we use the.
So always ready with bipolar electrode, unipolar Kelly's knife and scissor. Never think that you can complete with scissor only. Be ready with all the
We
tools.
should not use the cotton.
Yeah.
Got it. And what the extent normally you feel to cut the septa, like kahan tak kuch chhod de, always undo or do?
it is best thing that once you see both the ostia, stop your procedure. Once you see both the ostia, stop the procedure. There is no need to give beyond the ostial opening. Sometimes overcorrection may get uterus rupture. So under correction will be good, but don't do too much of under correction. Always do correction up to the level of ostia. Once with simple scope, you can see both ostia, then your septum resection is complete.
Okay. So, like there is one query, how much small septa you just feel कि you have to do? कुछ करना ही नहीं, very small septa. You will do or not?
There are so many septa you can do visualize during cesarean section. There are so many septa you can visualize through hysteroscope. When septa is very flappy, not thick, not reaching up to the midline, there is no need to do anything. Just let it be there.
That's what that's what I asked. Most of the time we feel there's a very small septa, and sometimes during the correction we are harming the endometrium.
It doesn't matter.
Sometimes it doesn't matter. So, Dr. Ranjana, are you there?
Yes, ma'am, I am there.
Hi.
Yes, ma'am.
So, I'm just need your expert comment. How do you feel about the class? Any queries or anything you want to add over there?
Yes, ma'am, I want to just know this thing. At the day 12 or day 14, if the follicular size is more than 15 mm or more than 60 mm, it is a follicular cyst, so-called?
No, madam.
Day of the cycle?
No, madam. This is you are talking about the stimulated cycle or just routine sonography?
No, just for the normal.
Up to 18 mm, it's normal.
Okay, and sometimes, sir, I just see it's 20 mm also for the day of 12, for the day of 13, like that.
More than 18, it is just going for cyst formation. Up to 20, you can call it, you can get some ovum from that if you are doing IVF practice. But it is for routine follicular measurement by either any ovulation inducing drug. More than 18 mm or up to 20 mm, it is normal follicle. More than 20, they are going for cyst. And if it is 18 or 20 mm, if you see very much cumulus oophorugus inside, then even if 22 mm will give you follicle.
Okay. That was the query for me. Thank you,
So
sir.
just see for cumulus. If it is there, if it is a simple follicular set, you won't see anything. And on that follicular set, put color. See the perifollicular flow. It won't be more than 25%.
Okay, sir. Okay, I understand that. Concept clear,
We can
sir.
confirm the E2 also, the E2 value. We can confirm that.
Yes,
So,
yes.
any other queries?
No, ma'am. Not for that.
Anyone of all of you? Otherwise, I will ask couple more questions with sir. No. Sir, you told like we can do cesarean mammectomy.
Yeah.
If the so suppose you are aware about the fibroid and the fibroid is not interfering anyway in the cavity, right? So what should be, and the patient has come to you for the preconception counseling. Everything is fine. I'm going to plan the pregnancy. So even though the fibroid is not affecting the fertility part, like it's not encroaching the endometrium, it's not near the ostia and all. So what will be the size of fibroid? You say it's okay, go on. Remove it at the time of cesarean. We are not going to put any scar over there.
Madam, even I had allowed pregnancy with 2.5 kg fundal fibroid.
So that might be accidental, but the patient has come to you for the
If the preconceptional counseling fibroid is not disturbing the endometrial cavity, fibroid is outside the endometrium, subserous fibroid, ignore it.
Okay.
Concept is clear. If there is no disturbance into the endometrial cavity, this fibroid don't cause any problem.
Got it. So
Sorry.
nothing to worry about. So sometimes the patients are worried, like if it is 5 centimeters, going to abort the pregnancy.
No.
Suppose, so we have to convince them.
We have to convince them. But be ready with the rate degeneration of fibroid. Because sometimes this fibroid can go for degeneration, and just simple paracetamol and any analgesic will do. But do frequent monitoring of all these patients. There are chances of preterm labor with multiple uterine fibroid because cavity is pressing. You won't get maybe more than 2.5 to 3 kg in this different multiple fibroid situation. And when there is multiple fibroid, it is better to go for laparoscopic myomectomy rather than shifting that patient for another surgery. Because that multiple fibroid we go for multiplication more. But with a single fibroid 5 centimeter, not going to disturb anything which is lying posteriorly in the fundus area. Even in cesarean hysterectomy, cesarean myomectomy doesn't require. It will become small post in involuted uterus.
So one thing is to individualize the thing, very
Yeah.
important, the mapping and all, and then the patient counseling and everything is very important. I agree with you, sir. I think Dr. Roshan has joined. Roshan, you missed the initial parts, na? We actually in the question answer session. Dr. Roshan is
Yeah, ma'am, I'm there.
yeah. Dr. Roshan is professor at Sector 9 Hospital, sir.
Namaskar,
And
welcome,
we-
madam.
Namaskar, sir.
So, if you had any query, you can ask your question. Otherwise, sir had gone all through the arcuate and mullerian anomalies and all. So, if there are any queries going in your mind or any questions or any case discussion, we can go through it. Okay. Sir, there was one thing like like endometriosis we didn't discuss grossly. What take on endometriosis? Like it's an infertility basis is there, and she had a bilateral endometriotic cyst of 5 centimeter, 4 centimeter on both the ovaries. Chocolate cyst 3.5 centimeter, 4.2 centimeter bilateral chocolate cyst. Young, 26, 27 year, married for 1.5 years. So what will your take on these patients?
First, we will talk regarding the 3 centimeter cyst. If it is a 3 centimeter endometric cyst and she want to conceive, I will just ignore single-sided 3 centimeter cyst. If there is bilateral chocolate 3 to 5 centimeter and there is dyspareunia, dyschezia, then there is difficulty in defecation.
No, so that will be pregnant, nothing, no other issues.
So if there is no issue, forget about it. You just go for stimulation. That will not go with any medication. If you are using Dynogest, it won't increase in size, but it won't regress in the size. So 3 to 5 centimeter is a gray zone. More than 5 centimeter, laparoscopy. Nothing. No gonadotrophy, no GNR analogs, nothing. But 3 to 5 centimeter is gray zone in endometriosis. You can stimulate, you can do ovulation induction, you can go for IUI, you can go for HSG, you can go for sonosalpingography. If there is no pain and only simple cyst up to 3 to 5 centimeter, you can stimulate. More than 5 centimeter, you have to go for laparoscopy. Simple.
So the single take home message is that if it is more than 5 centimeter, either it's unilateral or it is bilateral, we have to go for laparoscopy.
Laparoscopy, gold standard.
And if it is less than 5 centimeter, then we have to go for induction. Depending upon the age of the patient, we can go for IUI, we can go for the IVF.
Yes, madam.
Right, sir?
Yeah.
Okay, thank you, sir. And there was one more query, is like anyone can ask questions from the sir. I just forgot what I was going to ask you.
Sir, I wanted to know
Yes, madam.
when should anyone go for this myomectomy for in cases of infertility cases, sir?
If any fibroid is disturbing the uterine endometrium, either is it about 1 centimeter or 5 centimeter protruding into the uterine cavity, disturbing the endometrium, you have to remove it. Whether it is a submucous fibroid, whether it is an intramural fibroid, for subserous fibroid more than 5 centimeter, nothing to worry.
Okay.
Simple funda.
Thank you, sir.
So these last two questions of mine, if anybody is not asking.
Yeah.
The one is how do you differentiate between the polycystic ovary and the multicystic ovary?
You have to see Rotterdam criteria. You have to see the vascularity. I had mentioned all the points. Nowadays, Rotterdam criteria is also modified, and we are watching the uterine ovarian volume. It is 6 to 10 centimeters square. Then it is a polycystic ovary. And now the cobblestone appearance, necklace pattern has gone. The number of ovarian follicle, ovarian stroma with biochemical marker. You can see free serum insulin or fasting insulin. Then see the circulating androgen. Then you can combine all this. And nowadays it is not PCOD. It is PCOS, polycystic ovarian syndrome. It's a metabolic disorder. and you have to consider like this, and it is always separate from polycystic ovary.
So clinically, like when you are looking over a multicystic ovary, like polycystic, everybody is aware they can manage and they can look clinically and all
Yeah.
the criteria and all. So how do you clinically found in the scan what is the size of the multicystic ovary or any ultrasonographic differences like we can see?
You can also
Ultrasound finding.
ultrasound finding. You cannot differentiate that there is a polycystic or multicystic, but once you see polycystic ovary, there will be a thick stroma. The stroma will be thick, volume will be big. In multicystic ovary, stroma may not be thick, but you can see multiple follicle. Then put your peak systolic velocity. If it is less than 10, then it is a multicystic. More than 10, it is a polycystic. Then combine it with the chemical marker of free fasting insulin, and you can see all androgen, testosterone, and all this.
Testosterone. Thank you, sir. So in your clinical practice like this multicystic ovary, what is the outcome you feel? Like polycystic, we all know we will lifestyle and blah 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 blah. Normally, when you clinical experience, how these polycystic ovary patients behave like?
Usually, madam, in practical approach, we don't find that much of multicystic ovary in our population. You usually find polycystic ovary. But with multicystic ovary, you can go for ovulation induction. You can get 1 or 2 good follicle which are lying in the periphery rather than lying in the center. And this multicystic ovary, the small follicle will remain there, while in polycystic ovary, all follicle is growing. So in multicystic ovary, you can get 1 or 2 good follicle in periphery. You can stimulate and you can go for IUR, IEF like this. But the clinical scenario, the number of polycystic ovary is more rather than multicystic ovary.
Normally, I'm struggling with 2 patients. Like even I do the day 2 scan, there is a follicle of 4 to 5 to 6 follicles. You can say maybe and follicle, and they are 8 millimeter, 10 millimeter. Either go on day 10 scan, they are the same.
They are the same.
And they are the same. I will go for day 2. So I don't
This
know.
is a typical multicystic ovary. It won't respond to any gonadotropin. Because
So I think it's
you see, just like multicystic ovary and polycystic kidney, this multicystic ovarian cyst remains same on any day of scan. Day 2, day 3, day 5, day 8, they are with the same diameter. Polycystic ovary with stimulation, you can have an increase in the number of size. Multicystic ovary, they are remaining same. So if you don't find any good clinical outcome with it, multicystic ovary, advise them to go for womb donation.
Is there any role of downregulation in these multicystic ovaries, sir?
No, you are not able to down regulate this multicystic ovary because they are not hormone dependent. They are typical cysts in the ovaries. They are there, so it is not going to respond to any gonadotropin or GnRH analogs. Just try it will remain there.
Thank you. One last question, sir.
Yes, madam.
Like in unicornate uterus, do you prefer fundamentoplasty?
No, madam. No, because unicornate uterus accommodate baby very well. Usually there will be a positional difficulty because usually baby will be in breech position. But if cavity is good, volume is more than 7 or more than 6, don't try to do any injustice to that uterus by doing any fundal metroplasty. It is not needed because there is a big fundus of the unicornate uterus. If you do fundal metroplasty, there are chances of fundal rupture. So if cavity is good, banana shaped, very good cavity. If you do vocal will be 5 to 7. Endometrium is good. It is God wish that she should conceive with this unicornate uterus. And we have seen so many unicornate uterus pregnancy, and so many times you can see at the time of cesarean section that this is a unicornate uterus and patient is coming with breech position.
No, yeah. In case of arcuate uterus, do you prefer to do fundal metroplasty?
No. Even again, go for the same. If volume is good, nothing should be done. So nowadays, minimal intervention. If God has given this cavity and if she is able to conceive, let it be there. If she is aborting or if the cavity is not going for expansion, then you can go for hysteroscopic expansion of the cavity rather than going for laparoscopic surgery. You can got lateral metroplasty and you can increase the size of endometrium if there are chances of recurrent abortion is there in arcuate uterus.
So if there is no other queries,
Sir, ma'am,
Yeah,
sir, I
yeah,
have two
Dr.
queries.
Yes, Roshan
Sir,
madam.
is there any role of leuprolide in cases of infertility with fibroid? Because I have seen a couple of patients conceiving after that.
Yes, madam. Luprolide. That's why nowadays there is concept that you can use reduce the size of fibroid by drugs with injection.
Yeah.
Particularly in cases the fibroid size is 3 to 5 centimeter. If
Yes.
if it is protruding 1 centimeter in the uterine cavity, give them GNR calorox. You can give them lupride. You can give them OC pills. You can give them Renolarix that is recently available in market. You can combine
Yes.
with this drug that we are giving for fibroid, that is uripristal, and
Yes.
after 3 months you can allow them to conceive. And but fallacy of this drug, that once you stop that drug, there will be increase in the size of fibroid, or fibroid will get the same size.
Yes, sir.
So just after finishing your size reduction medication, allow them to go for concealment by IUI or IVF.
Okay, sir.
And there is a
And
very
sir,
good
one more
paper by
question.
Brussels people. The interview you can see of mine in Professor Herman Tournay. We had discussed a lot on this uterine fibroid, because as a laparoscopic surgeon we would like to remove it, but with
Yes,
medication
sir.
we are able to make little bit decrease in the size, and we are making endometrium more conceivable. You can call it a
Yes.
pregnancy conducive endometrium, and you can implant
Yes, sir.
embryo inside the uterine cavity.
Yes, sir. Sir, I have one more question.
Hmm.
Actually, I want to share my experience, sir. I had a patient, she has a cesarean section. At that time, a small fibroid was diagnosed, but nothing was done for that.
Hmm.
And she had a second pregnancy as abortion. She aborted that, missed abortion.
Hmm.
And she conceived for the third time, but didn't do anything for the fibroid.
Hmm.
She went up to term, we did a section,
Hmm.
but because of the fibroid which was pressing inside, she had deformity in the baby. Her both the foots were deformed.
That is
On
a
the
club
child.
foot, madam. That is a club foot.
But that was pressing, sir. We saw it in the section, sir.
Yes, madam. You can see it, and because the cavity is
It was being
disturbed,
compressed
it is compressed. So
inside.
baby will be of club foot, and this is a very correctable surgery, because there is no
But
space.
for a long time, the child had to wear those calipers, sir.
Yeah. For up to 6 months to 1.5 years. Depends upon
Yes.
the surgeon capability and depends upon the deformity.
That was very pathetic to see.
No, but
Then I was-
that was you can diagnose during ultrasound examination. Recently, one pathologist is there in my hospital, and she has
Yeah.
got one, because of that fibroid. One baby had one leg was telepus equinovarus. So we had advised them
Yes.
to go for surgery post cesarean section.
Okay. Yes. Thank you, sir.
Thank you, madam. Thank you. Anything more? Yes, madam.
I was little late in joining, sir. I missed
No
a
problem,
lot.
no problem,
I was
madam.
part of it.
Madam might have recorded, so you can see on this YouTube next day morning.
Recorded it.
Yeah.
Oh, that's great.
Hmm.
That's great. Thank you
So
so
I
much.
think there is no queries. Aarti ma'am, any queries is there, or should we close the class?
Because already 9:13.
9:30 time. So once again, I thanks Dr. Manish for
Thank you, madam.
such
Thank
a
you.
wonderful interactive session, and thank you all for joining. In fact, in the future also we will take your services with your kind permission. And thank you all for joining and making this session so interactive. Thank you. Good night and
Thank you. Namaskar. Jai Shri Krishna. Just I am.
Thank you so much, sir.
Thank you, Roshan madam, and thank you for
Thank
sharing
you,
your
sir.
case.
Thank
And you can see very well this is clubfoot in ultrasound. And if you inform patient previously, then there will be less discomfort.
Yes.
Thank you.
Thank you.
Thank
Thank you all.
you. Namaskar.
Thank you. Namaskar.
ऊपर से